Welcome to video 2 of the Safe Recovery Training Program. Why use the Safe Recovery Program to prevent falls in hospitals? I'm Terry Haines. The objective of this video is to understand the evidence base supporting the use of the Safe Recovery Program for the prevention of falls in hospitals. The Safe Recovery Program was created in around 2001-2002 as a part of my work at the Peter James Centre. I was a physiotherapist working there at the time, working to rehabilitate patients following all manner of diseases and illnesses and surgeries. And I was frustrated about how we were going about falls prevention on hospital wards because many of my patients were falling over and having their rehabilitation delayed, their discharge delayed, and were hurting themselves, and for some not being able to go home anymore. If we think about the process of falls prevention on hospital wards, generally there's informal discussion between nursing staff and patients, and quite often there's a mobility prescription either from the nurses or from other allied health team members such as physiotherapists or occupational therapists, letting patients know how far they're allowed to walk and if they're supposed to use a gait aid. There may be some informal discussion between different members of the nursing staff, particularly at handover. There may be falls risk assessment paperwork that assists in this, documentation, progress notes, verbal handover, and also a handover sheet. There may also be possible interactions with other members of the team, such as medical staff or allied health. However, we know that this rarely happens, and not in a substantive or meaningful way. And for those who want to find out a bit more about this and the problems that we face with providing information to older adults in hospital, I advise you get a hold of this paper. They'll tell me if there is a problem. Published in Health Education Research by one of my PhD students, Angel Lee. Now, prior to 2004, there were 3 randomized controlled trials that have been published looking at ways to prevent falls in hospital wards. Tadaixa et al. In 1993 looked at using bed alarms to prevent falls. Mayo looked at using falls risk alert bracelets, and Donald looked at using flooring, either carpet or vinyl, and also an additional exercise program focusing on hip flexion and ankle dorsiflexion strength training in addition to usual care. And for all of these studies, they are quite small, and none of them found a significant reduction in the rate of falls in their intervention group. And the Mayo study, in fact, was ceased prematurely because their control group was doing much better than their intervention group in terms of falls. So, back at the Peter James Centre, I had limited information to base what my falls prevention program should look like. So I created one that had a falls risk screening tool at the beginning, and that was based largely on the clinical judgment of the treating clinical staff of the patient in determining which of the following 4 interventions the patient should receive. First, a falls risk alert card and a family member falls prevention information brochure. One-to-one patient education, and that was the first version of the Safe Recovery Program. Also, an additional exercise program 3 times per week on top of usual care physiotherapy, which was daily, and the provision of hip protectors. This study was completed. We had over 600 participants in that study, and we got it published in the British Medical Journal, and it was the first trial to demonstrate that falls could be prevented in a hospital setting. The rate of falls was significantly reduced by about 30%. We had similar reductions in the proportion of patients who were fallers and the rate of falls resulting in injury, though these weren't significant because the numbers of these outcomes is lower, and therefore our trial had less statistical power to find this difference. I conducted a subgroup analysis of this data set. In this trial, both the intervention and control groups had the falls risk screening tool completed. It was only those in the intervention group who actually received the other interventions. What that meant, though, was that in my control group, I had a group of people who had been recommended to receive the one-to-one patient education program, along with the other interventions. And when I focused just in on the patients who had that recommendation for the one-to-one education in the control and the intervention groups, I saw that there was a near 50% reduction in the rate of falls. The intriguing thing with this finding was that it wasn't limited just to those patients who were cognitively intact, that there were those who were cognitively impaired as well who had a similar reduction in the rate of falls. These graphs here demonstrating the rate of falls on the y-axis over time since admission to the rehabilitation unit. And you can see that there's a big difference between the control and intervention group in the cognitively impaired patients as well as in the cognitively intact patients. This was an intriguing finding, one that wasn't anticipated. I think I called it serendipitous at the time, and recommended that we needed to look at this again in future. Now, the question quickly arose for me, was this worthwhile doing? Even though we could reduce falls, it wasn't clear whether we should be doing this or how we should be doing this. So I conducted an economic modelling study. Here we compared providing the education on its own to every patient, to no patients, or to just those selected as being at high risk by the treating clinicians. And we found that providing the patient education program to those high-risk patients would reduce both falls and be less costly compared with doing nothing at all. We did base this on a few assumptions, though, that there'd be a 20% reduction in the proportion of patients who became fallers. That's a relative reduction. That there was an 18% proportion of patients who become fallers in the control group, which was based on our data from the subacute hospital setting, rehabilitation wards. All patients benefited from the education equally, which was again based on that subgroup analysis finding. And also, we used a burden of disease estimate from Bates et al. In the United States, published in 1996. I was fortunate enough to then receive some funding from the National Health and Medical Research Council and support from the Menzies Foundation to work with a group of investigators in Queensland and Western Australia to conduct a trial of the education program in isolation. And it's in this trial that we added the use of video-based provision of information. So instead of just having a written workbook, we provided a video-based presentation that we showed to patients on a portable DVD player. And in this trial we had three groups. We had a control group that received standard care, a group that received just the video and the written materials in addition to standard care, and then a group that received the written materials, standard care, video materials, and one-to-one discussions with a health professional trained to provide the safe recovery program. What we found was that the results were different for patients who were cognitively intact as opposed to cognitively impaired. We found that the group that received the video and written materials only had no impact on the rate of fall. So providing just something that's written or just something that's in video-based format has no effect on the rate of falls according to the study. However, providing the one-to-one feedback as well was very important. For those who are cognitively intact, we found a near 50% reduction in the rate of falls and the proportion of patients who are fallers. Also, we found a near 50% reduction in the rate of injurious falls, though this last finding wasn't statistically significant, again because there's fewer injurious falls overall in a trial such as this. For the cognitively impaired patients, however, we found that the falls were not reduced and that the rate of injurious falls was actually increased for those who received the complete program, which was again a surprise finding. But if you combine this data with that from the first study, subgroup analysis, you come out at about even Steven in terms of the number of patients who have had an injury as a result of a fall who have been exposed to this program with those who haven't. This isn't surprising in a lot of falls research because this data is very volatile. You get a small number of patients who have very large numbers of falls. And what you'll notice here on this line is that the number of patients who had one or more falls in the study was 24 in each of the three groups. So it just so happened that in the complete program group in this particular trial, we had a small number of patients who had a very large number of falls. And that can always happen in a hospital environment. So if we consider what we'd done in these first two trials, We've added to what is usual care around the outside of this diagram with a person who provided the safe recovery program and directly communicated with the patient those fall safety messages that are contained within that program. However, this safe recovery person did not provide any communication with the nursing staff, medical staff, or any of the other allied health team members on the ward. The reason for this was because we randomly allocated patients within the same ward to either the intervention or control group. If we had started talking to the staff members about falls prevention initiatives for individual patients, then we may have gotten a confounding effect and a crossover from the intervention to the control group. So we made a restriction during these two trials that the patients were not allowed to directly, the safe recovery personnel were not allowed to directly discuss the patients with the existing staff members. With this model of service delivery, we're fairly confident that we reduced the rate of falls and the proportion of patients who are fallers amongst the cognitively intact, and had a trend for reduction in the rate of falls with injury amongst the cognitively intact. Amongst the cognitively impaired, though, we've had inconsistent findings across the two trials in regards to their impact on falls outcomes. We return to the question of, should we be doing this? Is it value for money? A number of the assumptions that we made in the first modelling study, listed below, were proved to be incorrect during the second trial. So we had to re-examine the cost effectiveness of providing the safe recovery education program. We conducted a second modelling study, and this is published in an open access journal in BMC Medicine that you can access quite easily. Just to sidetrack for a quick second, we found using this data set that we collected as a part of the second trial in Brisbane and Western Australia, that the cost of falls ranged between $9,000 and $13,000, or nearly $14,000 Australian per fall, and that for each patient who becomes a faller, the additional cost that they incur compared to those who don't become a faller range between $11,000 and up to as high as $26,000 per person. So there's some staggeringly large estimates of the cost per faller. When we look at the cost effectiveness of the education program, it very much depends on the assumptions that are made regarding how costly a fall is. The cost per fall that we calculated was used in this set of green lines here for the cost effectiveness. So if the lines are above this 0 mark, that means that the program is cost saving. So if we assume that the cost per faller was around $15,000, which is one of the estimates we calculated, then this program is a very cost effective program. However, if you use a very low cost per faller estimate, and this is this black line here is using a cost per faller estimate of only $58 per faller, and that assumes that having a fall has no impact on length of stay at all, then it isn't a very cost-effective program. But we didn't think that assumption was particularly valid, so we used a middle-of-the-road cost per fall estimate, again from that Bates study from the United States, and found that if the proportion of fallers was 4% on your ward, and that's amongst the cognitively intact patients, then it would be a fall saving and cost saving intervention. But again, all of this is very much based on the assumption that falls can have an impact on the length of stay of patients. The more you believe that falls have an impact on length of stay, the more cost effective the program appears to be. So what have we learned? We've learned that introducing a safe recovery program provider into usual care can be a cost-effective way to prevent falls, particularly amongst cognitively intact patients on wards that tend to have a high rate of falls. However, we didn't know if Allowing the safe recovery person to interact with other staff members of the team, could potentially have an equal or bigger impact on the rate of falls. This is particularly important because a lot of the information that was gathered between the patient and the safe recovery program provider was high quality information from a quality improvement perspective. Patients were telling us exactly what they felt about the care they were receiving and about the improvements they thought were needed in order to improve the safety on the ward. We'd had to hold on to that information ourselves during the earlier trials, but we wanted to know whether releasing that information back to the staff could have an additional benefit. So one of my colleagues, Associate Professor Anne-Marie Hill, who works in Western Australia, was able to receive some funding from the Western Australian government to conduct a trial to look at whether providing the safe recovery program to an entire ward was able to reduce falls in a similar manner. So we identified 8 rehabilitation units in Western Australia and used a cluster randomized controlled trial design known as a stepped wedge, and more information can again be found at this particular publication in BMJ Open about the design we used. These sites were randomly allocated to receiving the safe recovery program at different time points across 2013. The results of the study have recently been published in the Lancet. The rate of falls was significantly reduced, along with the proportion of patients who are fallers, and also for the first time the rate of injurious falls using this program. Interestingly, there was no interaction effect. The results were comparable amongst cognitively intact and impaired patients. So, we found that by having this model of provision of the safe recovery program, we had a reduction in the rate of falls outcomes in excess of 40% across the board. So, if we think about these studies are likely to be producing findings that are trustworthy because each of these 3 studies has been a very large and very powerful experimental trial. We've used very rigorous collection of falls data approaches. We've had people going onto wards, interviewing patients, hand searching through medical records, as well as searching incident reports. A lot of falls prevention studies in this field rely on incident reports alone, and this is a problem because approximately 40 to 25% of all falls are not recorded on incident reports, and this has been shown repeatedly across different studies in the United Kingdom, Australia, and the United States. Other reasons why our findings are likely to be trustworthy are that we've had concordant findings across the outcomes of falls, fallers, and injurious falls within each of our trials. We've had a substantial reduction in falls consistently identified. We've had standard care of high quality in each of the control wards, indicating that even if you think your wards are doing a good job already, that the safe recovery program can add value to it. These findings are important because this approach has been shown to consistently reduce falls in hospitals. This approach is the only one with any published evidence that it's a cost-effective way to prevent falls in hospitals. These results are also challenging, however, because it's a markedly different way to try to prevent falls than what is described in existing best practice guidelines internationally. This approach forces us to reconsider how we conceptualize the problem of falls prevention in hospitals, and this is something that we'll look at in our next video. This approach also requires managers and clinicians to change existing practices to insert somebody who is providing the safe recovery program in addition to usual care. The next video, again, we'll look at how we conceptualize the prevention of falls in hospitals using a risk-taking behavior reduction approach rather than a risk factor reduction approach.